It's very exciting to be in front of the frontline health workers who deliver the healthcare. I'm also thankful to my mentor, Dr. Mary Adam, who was my PhD supervisor, and Dr. Lydia Okutoi, who the mothers of quality. When I was doing my research, I didn't even realize that I was in quality, and we were having that conversation today morning. When you're a researcher, you're so deep in the work, you don't realize the umbrella term of what you're doing. You realize it later. So I'll speak on measuring impact and the metrics that have been utilized to monitor patient experience. And I'm really, really happy that my colleague Benta Omonge has really talked about the different metrics and how there's a lack of uniformity in the metrics. I also have slides because we're researchers and we have to cite very closely. Somebody said you can't steal stuff, so I can use my slides. So the next slide, please. So what are the metrics that have been utilized to monitor patient experience? I'll start with an example of community engagement in Brother Andre Hospital in Dandora. Next slide, please. Next slide, please. So I'll start with a little story. I don't know how many of you have been to Dandora. Raise of hands. Oh, a good number of people have been to Dandora. It's actually a very, it's a place on the east side of Nairobi, and the garbage dump of Nairobi is placed there. And it has a lot of stigma because of the crime that is around there. So the University of Notre is an American university that is Catholic and is owned by the Congregation of the Holy Cross, and they maintained a presence there from the 70s. And this Holy Cross has been engaging with the community that lives in very difficult circumstances. And when the university was called in to help engage with the community, we had sessions for listening and learning. So we had a one-year period where we just sat and engaged with different members of the community and asked them, what are your developmental problems? If we are to come in to intervene as the church community, how can we help you? The biggest problem that came up at the time that we did this work, this was around between 2011 and 2016, was access to healthcare services and access to quality healthcare services. And one of the things that was mentioned, for those of you who've been to Dandora, security was a big issue. And security plays out at night. Most women, I don't know how many of you have had babies, delivery happens at around 3 a.m., 4 a.m. in the middle of the night, and they were scared of going out of their houses because of security. So there was an access issue to maternal health services and also a quality issue. They mentioned that there was overcrowding at the time. I think at the time Mama Lucy had not really been opened, and most of them had to go to Pumwani Hospital because it was free. And they also mentioned that there was mistreatment of themselves when they went to deliver, particularly the younger women. So we decided to generate evidence through research, and we did a study to ascertain this. Next slide, please. So we decided to not rely on hearsay, but to structure this, to get the experiences and the voices of the women. So we did a year process of just conducting a study to ascertain these experiences that the women have. And we realized that they mentioned a lot of experiences of being abused by healthcare workers, and particularly the younger women and women from lower socioeconomic backgrounds. We published this, and it was a very sensitive process because they didn't want to talk. They said that if they spoke, the healthcare workers would ostracize them, but we assured them of the confidentiality, And one other thing that really helped our research team was we were working from the church basis, and the Holy Cross does a lot of work in the community. So anytime you're a researcher and you work from a base like that where trust has been established, they said that they knew that the congregation was working in their interests. And that's where this work led to the building of the hospital. They wanted a facility that was based on dignity and respectful care. So this is one of the studies that I authored on exploring the mistreatment of women during childbirth. It was a very, very emotional experience because of what was described, but we thought that we needed evidence to put in the interventions that we needed to put in. So next slide, please. So this is not unique to Kenya. Since we're in an African setting, mistreatment also happens in different settings. And during this time, this WHO commissioned a study to look at observations of how women are treated during labor and childbirth. And WHO published this study with experiences from 3 other African countries, so Ghana, Guinea, and Nigeria. I think Myanmar was one of the other countries. And they also found that more than 1/3 of women experienced mistreatment. They also found inequalities in the way women are treated in the health facilities, with younger women and less educated women at most risk. So this implies, again, that we need to understand the gender and social inequalities that are happening in the settings where people are receiving services. Next slide, please. So this slide talks about the Heshima project. Other people were also recognizing that this issue of mistreatment is a really big issue. And I really liked Benta's slides because it said 80% of factors that women and other people, patients experience in the hospitals are determined by factors outside of the clinical experience. And so the Population Council got funding from USAID in a project where they worked with the Ministry of Health, the Federation of Women Lawyers, and the National Nurses Association of Kenya Midwives chapter to examine the extent and causes of disrespect and abuse in Kenya. And this work directly led to WHO's implementation of prevention and elimination of disrespect and abuse during childbirth. So this issue is a really, really big issue that is emerging. We can see it in different African countries, and people are putting, people like the Population Council put in projects to address this. And the most important part of this project was it focused on training of healthcare workers on value clarification and attitude transformation. So this is just giving an example of how research can lead to actions that lead to interventions that lead to change at health facility levels. Next slide, please. Back to the literature. So the literature, since we are researchers, we look at how are quality indicators defined. What is a quality indicator? These are tools that measure systems performance and healthcare quality and demonstrate the extent to which improvement efforts have led to desirable change or contributed to unintended results. I think Benta spoke a lot about the tools that are present, but there are very many tools. Next slide, please. There are very many tools, and when you go down to patient-centered quality indicators, what are these quality indicators? When you look in the literature and do your searches, you find that there are several gaps in the definition. I looked at a systematic review, most recent, done around 2020, and the articles use the term indicator, but most of them did not present actual indicators as defined by the Agency for Healthcare Research and Quality. These are agencies that have really done a lot of work with IHI to define indicators. Next slide, please. So what are we saying are the challenges with definition of PCQIs. There's a lot of heterogeneity describing and defining the nature of patient-centered quality indicators. Most of them are presented as patient-centered measures, but they're identified in guidelines, in surveys, and in recommendation. And the systematic review I looked at showed that only 25 could be considered as actual patient-centered quality indicators. And the most important thing that came out of the systematic review is none of the identified articles implemented quality indicators in care settings. So I think this is really resonating what Benta presented. Very few of this is being done in where care is being presented. Next slide, please. So what is the challenge? The challenge is few of them are incorporating priorities and experiences of patients and caregivers. Then again, they don't explicitly define what the quality indicator is. And then lastly, there's an inconsistency in how an indicator should be presented. And I think this presents a challenge on how do we get together in common indicators. Lastly, the review, next slide, please. The review also revealed that when you're incorporating patient and caregiver perspectives in quality improvement, you need to translate perceptions and subjective experiences into standardized objective indicators if you're to do something about them. So I think Benta mentioned measures of well-being are both necessary and important to incorporating a patient-centered care model of care. And then the perceptions of health. This can vary between individuals, and it can vary across time, as well as experiences and expectations for healthcare. So in order to capture these different perspectives, it's vital to include patients and families, and it's necessary to have their voices so that we can get indicators that can really give us what quality patient-centered care is. So moving to, I want to give an example of one of the measures that has been provided by the WHO. Next slide, please. I think most of you have seen this WHO Quality of Care Framework for Maternal and Newborn Health. And on the right-hand side, where there's process, there's provision of care and experience of care. And the experience of care talks about effective communication, respect and dignity, and emotional support. And this is based on the WHO standards for maternal and newborn health care. And this is also based on studies, frameworks that previously built on work by people like Donna Bedian, who came up with the structure, process, and outcomes. I think they teach a lot of this in the IHI course that the panel presented here. And this experience of care is what some scholars have come to work on. So I'll give an example of one of the scholars who's leading in patient-centered maternity care, specifically for maternal and newborn. Next slide, please. So Dr. Patience Afulani is a scholar from Ghana. She's based at the University of California in San Francisco. I met her at a conference in 2018 in Liverpool. And she has developed a tool to measure person-centered maternity care in developing settings. And she validated this tool in a rural and urban setting in a Kenyan population. She worked very closely with Kenyan institutions such as KEMRI, and she did psychometric analysis to ensure that it was valid and reliable within these settings. Next slide, please. And we can see this person-centered maternity care scale has 30 items, and it expounds upon that WHO tool with the subscales on dignity and respect, supportive care, and communications and autonomy. And we see communications has a lot of questions there, and I think Benta also had a slide that showed that clear communication was rated at 95%. So this is clearly an area that people need to look at. And if you see the questions in communications, there are things like, did the healthcare providers call you by name? Did they introduce themselves while you're there? Did you feel that you're able to be in a position of your choice for delivery, right? Did they ask for consent before procedures on you? So this scale has 30 items, and it's contextualized to these settings. Next slide, please. So having met patients and her work, we did some work in Dandora again in examining person-centered maternity care in Embakasi. So we expanded the work in now the sub-county of Embakasi, just to see how does this play out in a peri-urban setting that might not be a rural and an urban setting. And so these are two papers that came out of that just to describe this work. Next slide, please. So the PCMC score that patient came out with was a total score out of 90 with those 3 subscales that I mentioned. And you can see how it plays out differently in the different settings. In Kenya, in the urban setting, she did the study in Nairobi, parts of Nairobi and Kiambu, and you see the scores are about 60.2, like the overall score for measuring the patient-centered maternity care according to those 3 subscales. In rural settings, she did the study in Migori County, 65.5. You see the rural area has a higher measure for quality of care as per the PCMC score. The study that we did, we got 58.2, and in Ghana, the study was done in a rural setting, and you see a lower number. So we're able to compare across settings using a tool that has been validated in those settings. Next slide, please. So the importance of this is, where should we focus our quality efforts? So these studies can be generalizable, right? Because the tool is valid and reliable. And the lowest scores were in communication and autonomy, followed by supportive care domains. And the highest scores were in dignity and respect. So over time, I think the issue of dignity and respect has been sorted out through access, through projects, through better staffing and all that. But within the interactions between the healthcare workers and the patients, or I like the term guests who come in, you start to see that a lot more work should be done, and maybe the communication specialists like Ruth Pearl should be coming in to train people. How do you interact within these spaces? Next slide, please. Then what else do we know about quality? I think I was so happy to hear Benta's presentation bring about preferences with 93%. So I did my PhD studies on measuring preferences using a health economics methodology called discrete choice experiments. This is a paper we did together with Mary Adam and my other supervisors, and we were looking at eliciting women's preferences for place of delivery. How do women make choices on where they deliver? So you can continue building facilities, staffing them, but people make choices on where they go based on certain attributes of these facilities, so unpacking them. And we did this study in Naivasha and Embakasi again in Dandora, and the results were very, very different. And in Dandora, we found that women ranked first health facility cleanliness. So that was very shocking. We thought, my hypothesis was that they would rank costs first, but the first ranking was cleanliness, followed by availability of medical equipment and supplies. Thirdly, the attitude of healthcare workers, and lastly, the quality of the clinical care, not clinical studies. And in Naivasha, the ranking was also different, and in both, costs came last. So we need to unpack, how do people make choices? If you're going to understand the patients coming in or the guests coming in through your facilities, you need to understand their choices, especially policymakers who are making decisions on resources. So this is just to say that there are other metrics that are also important in this equation of quality of care. We can do the quality of care as frontline workers, but also policymakers need to support us with understanding the populace. And as we all know, health systems are complex and they're constantly changing. Next slide, please. Yes, and so still in the topic of other metrics that we need to look at, Patience has done a lot of very interesting work. She, out of her series of studies, came to the conclusion that the healthcare workers are working under very stressful conditions, and this might be affecting the poor quality care. So she went and did a study to try and assess stress and burnout. And the results showed that 85% of providers reported moderate stress, 11.5 high stress, 65% low burnout, and 19.6 burnout. So these are issues that are coming up as very important. And within these results, she found out that female providers had higher burnout scores compared to male providers. So there's a gendered aspect there. So the research helps us to go granular and see what is going on with the healthcare workers that we expect to provide this high quality of care. I think one of the presenters on the first day had that public health thing of people being thrown further upstream. So we need to look at, as we do the root cause analysis, these healthcare workers that are shouldering this burden, are they stressed? Are they burnt out? And again, you see this result shows that support staff had higher rates of stress also, and providers under 30 years of age had higher, stress rates. So I think this speaks to something. We need to look beyond, and also, as sitting in the academy, we need to direct studies that are answering questions that are relevant for the things that we are facing. Next slide, please. I think this is my last slide. So what are the implications for quality improvement leadership? I think this is a leadership convening. We need to bring back the voices of patients and families through targeted research. How do we include them in research? How do we do research that can answer the questions that they're really asking? And then I think qualitative studies can help capture voices and experiences. They're really rich if you do them well, if you do them privately, and if you interact with the patients and their families in a way that you say that this is to lead to something that can help them, right? Then I think Benta really focused on this, using of standardized tools that are comparable, that can lead to direct changes, right? So I think the movement, we need to support the ministry and people like Acquire to come up with standards so that if it's maternity care, if patients as tool works for us, we can do it. And also the importance of using tools that are validated within the context. I really liked Patient's tool. I didn't have to go out as a researcher and make another tool. We used it, and now when I have master's students who want to do this in Garissa, I say, why don't you use this tool? Instead of trying to measure something in a way that has not been validated and doing the hard work of psychometric analysis. Then lastly, I think there's a need of use of other metrics. Benta mentioned choices. We need to study choices more. We need to study stress. We need to study burnout, things that are contributing to quality of care further upstream, so that we know what are the interventions that can be made at the system level that can give us a high quality of care at the end of the day. I think I'll stop there. Next slide, please. I'd just like to appreciate my PhD supervisors. Professor Gilbert Kokwaro is the director of the Institute for Healthcare Management. Professor Mary Adam, who has really mentored me in thinking about quality, and Professor Frank Wafula also is the director of the PhD program at Strathmore University. Thank you.